Is binge eating disorder more like an addictive disorder or an impulse control disorder? Would you expect medications for addictions to help, or rather medications for impulse control issues like ADHD? Hi, Jim Phelps for the Psychopharmacology Institute. Here we'll look at a review from the Journal of Psychopharmacology that provides some evidence regarding these questions and examines pharmaceutical treatment options. Spoiler alert, only a few survive scrutiny. Before going further, let's review the DSM criteria for binge eating disorder. It's distressing. There is a lack of control of eating, leading to 1 or more days a week of the following 5 problems, and person must have 3 for diagnosis. Eating large amounts, rapidly, to the point of discomfort, and/or number 4, eating alone because of embarrassment, and 5th, feeling disgusted or guilty afterward. So eating large amounts, rapidly, discomfort, alone, disgusted. This has to go on for 3 months or more and is not accompanied by compensatory purging, fasting, or exercise, or otherwise associated with anorexia or bulimia. Now, is binge eating disorder more like an addictive disorder or an impulse control disorder, or maybe a hypothalamic regulatory problem? The authors of this new review note that drugs that are approved to treat substance use disorders like acamprosate and naltrexone have not shown clear evidence of efficacy for binge eating disorder. They also assert that binge eating disorder is not a failure of the hypothalamic regulation of food intake, pointing at the failure of anti-obesity drugs to show efficacy in BED. They don't mention in this context research that suggests glucagon-like peptide-1 receptor agonists, semaglutide, and numerous others, could be candidates for study, as has been suggested by another research group. Instead, Drs. Heal and Smith focus on medications that work for ADHD, like dextroamphetamine, because in their view, the central problem in binge eating is impulse control. They cite studies showing that people with BED, binge eating disorder, have enhanced discounting, a preference for smaller immediate gains at the cost of larger delayed gains. Remember this from economics? The willingness to take a smaller amount of money now compared to a larger amount in 2 months? It's like the old marshmallow study, the one in which a series of 4-year-olds were offered 1 marshmallow now, or if they could wait 5 minutes and not eat it, they could have a second one, and they were left alone in the room with the marshmallow. I'll link a video in the references. They're very cute. And the idea is that people who meet criteria for binge eating disorder or ADHD have enhanced discounting. They're less inclined to wait for the second marshmallow, so to speak. Doesn't this suggest to you that a cognitive and behavioral approach would be a good idea? But this being a pharmacological review, Drs. Heal and Smith proceed into considerable detail regarding 15 candidate medications for BED that target impulsivity and weight loss. Studies point mainly at lisdexamfetamine. Everything else either doesn't work, has less evidence for efficacy, or production was discontinued after a lack of FDA approval. Lisdexamfetamine has a lysine attached to slow its metabolism and prevent snorting. Heal and Smith, whose company does consulting work for large pharmaceutical companies, don't mention a recent randomized trial of methylphenidate for binge eating disorder. Granted, it was small, 22 people on the stimulant and 27 people in the comparison group. In that small study, CBT and methylphenidate were equal in efficacy for binge episode frequency. Methylphenidate was associated with more weight loss. Well, at least then, there's at least one study to suggest that stimulants as a class have efficacy in binge eating disorder. Nevertheless, Heal and Smith's article does provide a look at medications that could target both impulse control and weight loss, and here are quick details for 9 of them. Phentermine differs from dextroamphetamine by a single methyl group. It has a powerful dopaminergic effect, and there is a 1999 study in ADHD that showed benefit. It's still used for weight loss, but it hasn't been studied for BED except in combination with other drugs. Modafinil, it's a stimulant, but it's not clearly dopaminergic. One randomized trial has tested modafinil in binge eating disorder, but with only 30 patients in each group, the lack of efficacy relative to placebo could have been because the study was underpowered. There were some positives among the secondary analyses. Bupropion has been evaluated in BED where it did produce weight loss, especially when given with naloxone, but in one study it didn't reduce food craving or binge frequency. Atomoxetine has been evaluated in one small BED trial where it produced modest improvements in the craving part, but clinically insignificant weight loss. Topiramate, its adverse effects were just so bad, mainly cognitive impairment, that all study in obesity and type 2 diabetes has been halted. Rimonabant is a cannabinoid antagonist and inverse agonist that was withdrawn from FDA consideration back in 2007. It did reduce weight, but had no effect on binging. Acamprosate, well, it's useful for alcohol dependence, but doesn't have any effect on binging. And naltrexone, there are no trials in binge eating disorder of naltrexone as monotherapy. And samidorphan is dismissed as ineffective in this review, although there is a larger literature on opiates in eating disorders that isn't examined here. In summary, for the treatment of binge eating, CBT works, and so does dextroamphetamine, and perhaps stimulants as a class. For more on this, some balance would be achieved by looking at some literature on CBT for BED, which I've linked in the references.